So Dr. Francesco Mangano is currently the Mary Jane and Bob Trich Chair and Professor of the Neurological Surgery and Pediatrics at Cincinnati Children's Hospital Medical Center. He joined the Division of Pediatric Neurosurgery in July 2005. Dr. Mangano completed his neurosurgical residency at Long Island Jewish Medical Center in 2004, followed by a fellowship in pediatric neurosurgery at St. Louis Children's Hospital in St. Louis, Missouri. His academic endeavors have accounted for more than 100 publications as well as numerous book chapters. He has presented his work nationally and internationally. He has studied Chiari-1 malformations in the context of divisional practices at Cincinnati Children's Hospital Medical Center and has participated in and has been an author as part of multi-institutional and international collaborations to better understand the complexities of this condition.
Well, thank you for the introduction, and I'd like to start just by thanking the Bobby Jones CSF Foundation for the invitation to put together this talk and provide you with some general information. I wanted to really give a nice overview of Chiari-1 malformation in our pediatric population and specifically talk about the presentation and some controversies in associated conditions and management. So a brief outline of what we're going to be talking about today will include a historical perspective, definition of different Chiari malformations, the natural history. We'll provide some brief slides on clinical presentation, imaging, associated conditions. Not all of the associated conditions, but some of the more common associated conditions that I was able to find some extensive literature on that we could discuss. What the clinical decision making might look like, certainly some personal points of views from me, but I'm sure everybody in the room knows the understanding that this is a controversial topic, and different individuals will certainly give you different opinions. Some surgical options, and then we'll finish with some general conclusions about the topic. So from a historical perspective, really the first described case of a Chiari malformation happened in 1883 by Dr. Cleland. It wasn't until a little bit later that Dr. Chiari reported on a number of patients with hindbrain herniations and identified 3 different types. And then finally, Dr. Arnold described a case of a Chiari-2 malformation a number of years later. And so the coined term of Arnold-Chiari malformation came about as a result of that. Some definitions. The first thing to keep in mind about the definitions is that the Chiari-1 through 4 definitions is not a continuous spectrum of malformations, although they all have the same last name. And I'll talk about Chiari-1 in just a minute, but the Chiari-2 through Chiari-4 malformations are also different. Chiari-2 type malformations are generally associated with open neural tube defects and abnormalities of caudal displacement of the cerebellar vermis, the fourth ventricle, some lower brainstem into the foramen magnum. The type 3 and the type 2 malformation, if you look here on the lower left panel, this is the same patient having a fetal MRI early on, and then a postnatal MRI demonstrating some of these findings of a type 2 Chiari malformation. A type 3 malformation is evidenced here in the middle of the screen, and really this is, as it states here, caudal displacement of the cerebellum and brainstem into a high cervical meningocele. You can see how that is a lot different than the Chiari-2. And then finally, a Chiari-4 will be cerebellar hypoplasia, where really very little cerebellum is seen. Now, what about the Chiari-1 malformation? The Chiari-1 malformation is an imaging diagnosis. And in the most simplest terms, it's a downward displacement of the cerebellar tonsils, usually to a level of about 5 millimeters below the foramen magnum. It is generally thought to be congenital. However, there's no specific gene that relates to the Chiari-1 malformation. This is probably going to turn out to be a multigenetic, multifactorial association in families where we've seen the Chiari malformation occur. The literature would tell you that there's a familial association between 3 and 21% in families, as I mentioned. It can be associated with spinal and skull base abnormalities, and up to 50%. There's an association with hydrocephalus as well as tether cord. You can see here on this particular image, it's a sagittal view, a T1 MRI that shows the tonsils significantly below the foramen magnum with a small cervical serings here. We'll talk about some more of these findings as we move on here. Now, some of the more controversial additions to the Chiari-1 spectrum are the Chiari-0 malformation and the Chiari-1.5 malformation. The Chiari-0 malformation is generally described as a tonsillar herniation of less than 3 millimeters with a symptomatic serings that improves after a decompression. And so that is evidence on this panel here on the right side of the screen, where you can see preoperatively this patient has what one might consider a mild Chiari-1 malformation, a very large serings in the cervical spine that then resolves for the most part after a decompression. The Chiari-1.5 is an example here on the left side of the screen, and typically this is defined by increased crowding at the foramen magnum, usually displacement of the brainstem below the level of the foramen magnum as well as the obex, and these are the patients that are more likely to fail and have a persistent serings after a decompression. We'll talk a little bit more about the Chiari-1.5 a little bit later when we talk about associated conditions with it. What is the natural history of the Chiari-1 malformation? Well, the imaging incidence based on the literature is roughly 3.6% in the pediatric population. Roughly 70% of patients that are identified through this imaging incidence are not symptomatic at the time of their presentation. There is a wide range of literature describing syringomyelia. Roughly between 20 and 75% of patients that have initial imaging have a serings on their initial imaging, with the majority of those patients having a serings in the cervical spine if it is present, and roughly 1 in 5 patients having a holochord serings at presentation. There's also a prevalence that is higher in younger children that suggests that tonsillar displacement actually decreases as you reach younger adulthood. In a recent review done this year, looking at the natural history of Chiari-1 malformations, this particular paper reported on 700 asymptomatic children that did not have a serings on their original presentation. Roughly 5 to 6% of those patients developed symptoms over time as they were observed, and about 2 to 3% of patients developed serings over time. There have been an additional 100 published cases that have shown that symptomatic patients tend to have improvement over time, and only about 7% are worsened with observation only. So therefore, based on some of these findings in the medical literature, there is enough data to warrant watchful observation for patients that have non-symptomatic Chiari-1 as they present as children. And the natural history more recently would tell you that there's maybe a more favorable history than previously acknowledged in the literature. A little bit about clinical presentation. As I mentioned earlier, most commonly this is an incidental finding. Patients that do present with symptoms, however, generally present with headaches and usually high cervical pain that can be associated with activity or Valsalva type maneuvers. In our pediatric population, it's not uncommon to hear a typical presentation of a patient or a family member telling us that the child loves to play on the playground, run around, and after a short period of time they'll have to stop because they're feeling some discomfort. They can't quite perhaps tell the parent exactly what it is, but after a short rest they get back to playing and they're doing better. Other symptoms can include weakness, which can be upper motor neuron type weakness, incoordination, and then some brainstem symptoms that are typically seen in the younger population versus the older population. So swallowing difficulty, central sleep apnea, or even nystagmus or abnormal eye movements. Syringomyelia itself, as I mentioned earlier, can present in a wide variety of incidence, roughly between 20 and 75%. It is generally described as a enlargement of the central canal, which is a normal anatomic structure within the spinal cord. is generally associated with pain and sensory deficits when it is symptomatic, and can also be associated with progressive scoliosis. The general treatment for patients that present with syringomyelia is usually to have a surgical decompression at the craniocervical junction, not necessarily the management of the syrinx directly. There are some folks out there that will advocate for watchful observations for patients that are not symptomatic with a small syrinx, and again, that is of debate and controversy. The image here on the right side of the screen will show you that this is a patient that presented with significant Chiari and quite a large syrinx in the cervical spine that then improved after appropriate decompression at the craniocervical junction here. On to radiographic imaging, and we'll talk about different kinds of images and their worth to specifically patients with Chiari-1. X-rays can provide significant information about the bony anatomy of the skull. Certainly if the sutures are fused, or diagnosis of craniofacial syndromes. However, obviously they don't tell us much about the Chiari-1 malformation itself. CT of the head can also show low-lying tonsils. However, it doesn't really demonstrate a lot of detail. I wanted to show that to you with this image. Is axial CT in the lower left part of the screen, where you see the arrow here that is pointing to low-lying tonsils, and the brainstem right in front of that. It's really difficult to see the details of that, but the lack of CSF would tell you that there's some crowding going on there. CTs can also be helpful with 3D reconstructions, and as you can see that here on the right side of the screen, this is a 3D reconstruction of a CT of the head and cervical spine that can certainly be very helpful in planning a surgical decompression, especially in patients that have craniocervical abnormalities. The middle image here shows you someone with Klippel-Feil syndrome, where the cervical spine bones here are quite fused together. However, that MRI of the brain and spine is the test of choice to evaluate for a Chiari-1. It also gives you very exquisite information about the brainstem, exquisite information about even the bones of the cervical spine. Here, for example, you see a patient with a retroflexed odontoid, some herniation of the brainstem down through the foramen magnum. And can also give information about the brain itself. Here's a patient with very large ventricles and some level of hydrocephalus on their sagittal images. So speaking of hydrocephalus, moving into some associated conditions with the Chiari-1. It is actually described early on. Dr. Chiari's first case was of a patient that also had hydrocephalus identified on their postmortem evaluation. It is generally reported to be associated with 7 to 10% of patients with Chiari-1 malformations, and the literature would give you a range between 2 and 18%. It does have a higher association with craniosynostosis and other craniofacial syndromes, and others have tried to describe different hypotheses as to how hydrocephalus may develop or be a consequence of the Chiari-1 malformation. So this table here, algorithm that I pulled from a recent article, shows Dr. Chiari's original hypothesis here on the left side of the screen, where he postulated that there was a primary obstruction of CSF flow that caused hydrocephalus, and then pressure from above pushed the tonsils down, causing the Chiari-1 malformation. Similarly, there's a multifactorial hypothesis for this condition, which looks at two different initiating factors. One would be a hypoplastic posterior fossa with stenosis at the jugular foramen, which increases venous pressure. See here, and the increased venous pressure then causes hydrocephalus and a Chiari-1 malformation as an expression of the venous engorgement that occurs. Similarly, another hypothesis really revolves around the hypoplastic posterior fossa with a hyperplastic cerebellum, so a small container with a lot of contents within it. And this leads to a craniocerebral disproportion which then causes overcrowding structures in the posterior fossa and the Chiari-1 malformation. This Chiari-1 malformation then causes impaired CSF dynamics and then in return hydrocephalus. The reality of the situation is that we really don't know how this occurs, and the truth in all of this lies somewhere in the middle of all of this, but really we're not much further along than we were many years ago when these hypotheses were described. Now, what about hydrocephalus after surgery? We had the opportunity to be part of this study that included 6 different tertiary centers around the globe, really. It looked at 549 patients that had decompression for a symptomatic Chiari-1, and it reported an occurrence of 5.1% of patients developing hydrocephalus after the Chiari malformation was decompressed. The typical presentation was primarily with headaches, nausea, vomiting, and some patients presented with CSF leaks as well. Most patients required some sort of management for these symptoms, whether it was medical with some temporary CSF diversion like an external ventricular drain, or even leading to a permanent CSF diversion like an ETV or a VP shunt. And most of the patients ended up requiring this permanent diversion and did quite well ultimately, but nevertheless there is a certain occurrence of this condition in this patient population that many times does not demonstrate itself until after the decompression has been completed. Other associated conditions that go along with the Chiari-1 malformation are scoliosis. This was actually described not too long ago. The first description really was in 1988. There certainly appears to be enough evidence in the literature to support a relationship between the Chiari-1 malformation and scoliosis. The patients that do have both tend to present with an atypical presentation, for example, earlier than most, or with a left apical curve or a kyphotic curve, and more commonly with some neurologic deficits. What you're seeing here on the images off to the right are patients before and after a Chiari decompression, Chiari-1 decompression, which demonstrates good relief of craniocervical junction compression and some improvement in the curve, and certainly no worsening in the curve. General management for these patients really is initially with X-rays. A total spine MRI should be obtained at least once in anybody who is worked up for a Chiari-1 malformation, and following that, depending on the diagnosis, really close follow-up for progression of the scoliosis or symptoms if the patient presents without any symptoms. There is a recent study that was published just this year looking at many different patients with radiological findings of scoliosis as well as a Chiari with a syrinx. Of the 825 patients reported, roughly 31% also had a scoliosis. And those that had a scoliosis were associated with wider and longer syrinxes compared to the patient population that did not. In looking at predictors through a regression type analysis, it was determined that the cervical syrinxes and the holocord syrinxes were more predictive of a scoliosis than those that did not, with an average curve of about 30 degrees. And also of interest in this particular paper is that tonsillar position was not associated with the scoliosis. In general, for this patient population, the surgical management is reserved for patients that progress, patients that fail conservative management of their scoliosis, or for the treatment of a syrinx. Other associated conditions with Chiari-1 are craniocervical abnormalities. A lot of this work was done at Primary Children's and University of Utah, but some radiographic measurements have been described in the literature that seem to correlate relatively well, quite well, I would say, with the need, some instability or the need for fusion when surgery is indicated. And so on the left side of the screen here, you will see a diagram describing 3 different lines. The first one at the top is the posterior Bayesian C2 line that is drawn as a as a dot here coming down to the back of the C2 vertebral body, and a measurement is made as to the indentation here, and the numbered measurement that seems to be significant is 9 millimeters, and patients that have greater than 9 millimeter measurement are defined to have a retroflex odontoid. The other measurement is for basilar invagination. Here we see McRae's line being drawn across the clivus to the back of the occiput here, and really the dens should be below this line, really up to 5 millimeters below this line. If the dens is certainly above this particular line, you have a diagnosis of basilar invagination. Finally, the claviaxial angle here of 125 degrees is another important measurement that seems to be significant in the evaluation for craniocervical abnormalities with Chiari 1. So based on this measurement, these three measurements, and of course symptoms that go along with the patient's presentation, this diagram here shows patients presenting with a simple Chiari 1 malformation and those presenting with a complex Chiari 1 malformation. And what you see here is that if you follow the lines or the arrows from the complex Chiari 1 malformation, those patients that have a BC2 of less than 9 millimeters and a clival angle of less than 125 degrees tend to progress to effusion roughly 13% of the time. And those that have a BC2 line of less than 9 and less than 125 degrees to a much lesser degree proceed to effusion. However, on the other side of the spectrum here, those that have both greater than 9 millimeter and less than 125 degrees, 83% of those patients will tend to actually progress to a surgical decompression with or without duroplasty and occipital reduction or an occipital cervical fusion, with persisting symptoms then proceeding to an anterior procedure, which is also very invasive. So what about surgical options for patients with the Chiari 1 malformation? Well, I think as many opinions as one can obtain, you will get as many different options. And they're all part of the same continuum of surgical options, but much has been written about the best way, or at least individual series, in how different institutions and different individuals have achieved good results. So from least invasive to perhaps most invasive on this particular slide, you will see that some will opt for a bony decompression of the foramen magnum only. Others will opt for this with as well as the addition of a C1 laminectomy, a bony decompression that also includes a duroplasty, a bony decompression that will include a duroplasty and tonsillar shrinkage, or even resection of the tonsils at that point. With these options of surgical decompression of the Chiari, then there's the additional considerations for the occipital cervical fusion, our anterior decompression and fusion, management of hydrocephalus that goes along with the Chiari 1, or management of scoliosis. And this is certainly not an exhaustive list. I could think of other ways that Chiari 1 could be decompressed, but these are, I think, the most common ways that we run into. So here's an example of a Chiari.
Can I ask a question for the uninformed? What's duroplasty?
Sure, yes.
I mean, I'm sorry to be heard.
Sure, and we'll get into it a little bit further, but a duroplasty is essentially when during the posterior fossa surgery, we open the dura. The dura is the covering of the brain and spinal cord, and from that we then generally sew in a patch or some sort of material that will essentially create more space at the level of the decompression, that will then allow more CSF to surround the tonsils, surround the brainstem, and hopefully decompress appropriately to improve the symptoms.
Thank you.
So I wanted to show here an example of a specific Chiari-1 clinical treatment algorithm to just really use as an example of how complicated things can get. It's really, if you remember at the beginning of our conversation, I said this is really just a radiographic diagnosis, but that is a gross understatement, and I did that on purpose because as you get into this topic and you start peeling back the layers, you realize how complicated really what we're dealing with is. And so here's a specific group that came up with a specific algorithm for the way that they manage their pediatric patients, and not really going into all the details of what this shows, but generally speaking, you will find different treatment algorithms like this in the medical literature that are based on, first of all, the patient, the symptoms that they present with, the imaging findings that they present with, and the associated conditions that they present with. And we talked a little bit about that on the previous slides and how really the treatment arm is going to look a lot different if you have simply say a 7 or a 10 millimeter Chiari that's causing occipital headaches versus someone who's presenting with that in a syrinx versus someone who's presenting with that in some cranial-cervical abnormalities, for example. Additionally, decisions are going to be made on what's out there in the medical literature, what's been peer-reviewed and accepted, what the specific institutional experience is like of the physicians that are a part of these studies, and then really what the individual surgeon experience also is like, because each of us have slightly different backgrounds, slightly different experiences, and certainly that's going to affect how we may approach a particular patient. So decision-making in and of itself is not as simple as it perhaps I've been making it to sound up until this point. There is no known medical treatment for the Chiari-1 malformation. In general, if a patient is identified and is not symptomatic after a careful history of physical, watchful observation is a good general rule. If a patient presents with the appropriate symptoms, then surgery is usually recommended. So that's a very simple algorithm, right? So one or the other. But the treatment options are certainly varied, as I tried to show you, and controversial. The goal of the surgery, once surgery is recommended, however, is identical regardless of what you choose to do. You want to do a few things. You want to restore CSF, the dynamics. You want to alleviate the symptoms. You want to reduce the syrinx cavity if the patient is presenting with a syrinx, or at least stabilize the syrinx cavity. And if there's a progressive associated diagnosis like scoliosis, you'd like to see that progression stop and maybe even revert. So I wanted to just briefly go through an example of a surgical procedure, giving you a little bit of flavor, if you will, in what we like to do here in our institution. And I have to thank the Mayfield Clinic for these wonderful images that have been created and shared on the web many, many times. But we have the benefit of having the Mayfield Clinic in Cincinnati, and certainly appreciate the diagrams, to say the least. In general, in speaking about the bony anatomy and what the decompression might look like, we recommend about a 3 by 3 centimeter decompression. Now, this all depends on the patient size and the fact that we treat pediatric patients. The older patients may have a slightly larger decompression. The younger patients are going to have a smaller decompression because their anatomy is certainly smaller. We generally remove the posterior arch of C1 to provide, again, more room, and we generally thin the dura before we proceed to the next step. We like to do that because we use intraoperative ultrasound during our procedures. And what we are doing with the use of the intraoperative ultrasound is that we're evaluating the tonsillar anatomy in general. So what that means is that once we remove the occiput and the posterior ring of C1 here, we have a space. We fill that space with fluid, as you can see in this photograph here, and the ultrasound probe then gives us very nice images. Here are the tonsils in a sagittal plane. This is the spinal cord and brainstem as it proceeds from the feet up to the head. And what you're seeing here, this measurement that's been made, is that you're seeing about 2 millimeters of CSF space that wasn't there before, as well as the bottom of the tonsil is showing you cerebrospinal fluid as well. We look at the tonsil anatomy. We like to see rounded tonsils as opposed to pointed tonsils, as is evidenced here in this image. That usually tells us that they're certainly under some pressure there. And then finally, the nice thing about the ultrasound is that it's a dynamic image, and it gives us a sense of what's happening from a motion perspective. And what we don't want to see is pistoning of the tonsils down into the C1 region. If the tonsils are moving in this direction and compressing the cord and brainstem as they make this motion, generally that means that the bony decompression has not alleviated enough compression and allowed enough CSF to build around the tonsils that we then proceed to open the tonsils and shrink them to provide more room. And so the next step, if we move forward with the procedure, is that we make an incision in the dura and start our duroplasty. There are some important anatomic considerations. Is once you open the dura here, you're looking at a very significant anatomy, including the tonsils, but also very significant arteries, the vertebral arteries that come up through the back of the cervical spine, as well as the posterior inferior cerebellar arteries that loop around and many times are obstructing the obex or the bottom of the fourth ventricle as we shrink the tonsils. Finally, one of the most important things when we open the dura is that you want to get a watertight dural closure as you put in your patch. So this goes back to the question that was asked just a few minutes ago, and you can see in this very nice diagram, this is what a dural patch might look like. The incision is a straight incision that extends from roughly halfway down the tonsillar peg to an area where you're below the C1 bony removal. And then an elliptical shaped patch is sutured once the decompression has been completed to, again, provide more room in that location. Now, what about general complications? Well, the things we want to avoid if we open the dura, and I think a lot of the controversy behind bony decompressions only and dural opening is related to the fact that you are putting yourself at risk for a greater number of complications if this happens. And so the CSF leak is the most important, if you will, because one, it can lead to further symptoms, and certainly if CSF is leaking through the skin, it puts the patient at risk for a meningitis or an infection. Infection being another general complication, the risk of hemorrhage, again, once the dura is open and you're performing the procedure within the compartment. Cranial nerve deficits certainly can arise. Meningitis, which can be an aseptic meningitis or an infectious meningitis. If you create a very large bony decompression, you can end up with something called the cerebellar sag that in and of itself can also cause symptoms. In a recent review and a meta-analysis of 145 articles, just to put some numbers to these complications, it's generally reported that surgical complication rate for a Chiari-1 decompression is somewhere in the neighborhood of about 3 to 5%, with a larger range of patients developing worsening symptoms between 5 and 18%, and a reoperation rate of roughly 16%. Common reasons for reoperation, you can see listed here. Hydrocephalus certainly can lead to further surgical management of this problem. Craniocervical junction instability as well. Arachnoid scarring that can then close down the areas that have been open and cause recurring symptoms. And then dural graft complications, where the dural graft is not watertight, for example, or causes scarring and then causes symptoms once again. So some general conclusions, then I'm happy to answer any questions about this. The first thing that I want to say is that the Chiari-1 malformation is a simple condition to diagnose. Now, again, I wanted to make that comment sort of as a tongue-in-cheek sort of comment because we're all here talking about a very complicated condition. But if we think about the diagnosis of it, it's really relatively simple. We look at a sagittal image on an MRI, and we make a couple of measurements and basically tell someone you have a Chiari-1 or you don't. From that point on, things become a little bit more complicated. Now, the majority of patients, as I mentioned earlier, are not symptomatic from this condition. We generally just watch them repeat images every year to every couple of years while they're growing and make sure that they don't develop symptoms or something changes that warrants a different kind of approach. Now, for those that have symptoms and have an appropriate workup, which should certainly include an MRI of the brain and an MRI of the total spine, surgical decompression is usually successful in relieving general typical symptoms. Specific and optimal surgical management, as I mentioned earlier, is very controversial and certainly is a subject of much ongoing current research, and we hope that in the next 5 to 10 years we'll have a much better idea on what the recommendation for a specific procedure will be based on the patient's presentation. However, and in addition, there is a small subset of patients that present with a very complex constellation of symptoms. Those patients make the clinical decision-making very difficult. So what are some of those conditions? Those are some of the things we talked about. Patients that present with the syrinx, patients that present with scoliosis, hydrocephalus, different kinds of genetic syndromes, or craniocervical abnormalities. These certainly raise the level of difficulty in managing the patient to a much different level. So finally, what I would say is that this particular diagnosis garners significant attention from clinicians and researchers, and the good news is that there is a lot of research going on in this field. There are many centers that are dedicating significant resources to learning more about Chiari-1 malformation and these associated conditions that we briefly touched upon today. And I do think that future studies are going to lead to a better understanding of really the appropriate management, the best management, the best patients that are going to do well from surgery and patients that are going to do better from maybe conservative management or some other type of management that hasn't even been described yet. With that, I'm just going to give you a brief list of references that I talked about here. And it's just a few. It's just a few. And I'll say thank you for your attention. I'll just briefly introduce here. This is our Department of Neurosurgery in the white coats on the left side, and in our Division of Neurosurgery on the right side. You can see we're a little more laid back. But nevertheless, we can't do the work that we do every day without the help of all of these individuals that really get us through the day and get us to see our patients in the appropriate time frame and help us in the operating room. So thank you.
Thank you.